Good morning. We're going to get started in just a minute. Good morning. Thank you for joining us. It's 9:01, so I just want to give people a moment to get to their seats and welcome the folks that are calling in online. Cassandra, I see you here. Thank you for joining online. I see Matt as well. I'm just calling out some of our task force members. Matt or Cassandra, do you want to just check to see your sound is working okay, or you can give us a thumbs up as well?
Good morning.
Yep, my sound is working.
That's great. Thank you. We hear you both. All right. Excellent. Well, let's see if we can. I didn't like this. Awesome. Thank you. I'm like struggling to get my taskbar up. I don't know what happened here. I have one of my virtual no, pin menu. Let's just add this. Thank you. It's going to work. Thank you, Kristen. All right, good morning. Welcome to meeting number 3 of the Provider and Payer Advisory Task Force, working on behalf of the Center for Healthcare Affordability at MDH. We really appreciate your ongoing attention and time to this work. I know it's a busy time for many, especially with young kids coming out of school. That's where we are at the moment. We have a full day packed for you today and want to just jump in, but I do want to acknowledge, I want to appreciate, and we'll be hearing more from our co-chairs. This is the first time you have co-chairs sitting in the room with you. So Gita Worcester and Joel Beiswinger, we are really grateful for both of you to dive in with us, and they've been great partners with us to think in between meetings about how to really elicit this group's expertise. So you'll be hearing more from them. We also have Sheila Cascaden in the room, our Healthcare Affordability Advisory Task Force co-chair, and Matt Anderson on the phone, who is getting some well-deserved time away up north with family, but is calling in and eager to participate today. And so again, you'll be hearing more from all of them, but just want to thank them publicly for their continued support of this work and helping us really shape the work together with you all. Today, one of the reasons we wanted to get both of the co-chairs really here today is because I think of this as kind of a milestone moment for this group to be weighing in as the consultative partner to the Healthcare Affordability Advisory Task Force as it makes its first statement about where it sees priorities, where it sees the opportunities for Minnesota to make healthcare more affordable. And so today we're going to be taking kind of a structured approach to walk through and look at some of those priorities that are coming out and invite this group to weigh in and offer, how do you want to see that work happening? Where do you all see the opportunity to weigh in and shape that research and shape that policy development going forward? Because that's really what's coming next. So the policies are not there, but the topics are sort of are coming out. And so that's where we want to spend some time today. We're going to start just by reorienting to this group's role. We're going to hear from the task force chairs and just look back a little bit at how did we get to this moment? Because there's some things that haven't happened yet. For example, there's some really deep dive research and policy development that needs to happen next that hasn't happened yet, right? Really, we've done some prioritization with these groups. And so we want to just just remind folks where we've been, but then we're really going to spend most of the time walking through the topics. So yeah, most of the time just talking about the topics. We will have a break in the middle, but we'll start out hearing a little bit more from the co-chairs. A couple of just housekeeping things, not just in the room. First of all, welcome to a new space. We really appreciated working with Wilder. They were a really interesting community asset for Minnesota. So I hope you'll learn more about them and use the space. Bathrooms down the hall. Slides will be available on the center's website. We do have a number of folks calling in today. Thanks for staying on mute, just so people can hear. I want to just orient you to the microphones today. Please do unmute them. You can unmute them at any time. They're not going to pick up a whole lot of kind of external noise. They're not going to provide feedback or anything, but just don't forget to unmute them when you talk. And we would invite you to really speak into them so people can hear online, and that they're also amplified in the room. We'd also invite you to just say your name so that people can follow along online. So thank you for just continuing to make these meetings accessible to people that aren't in the room. It's really helpful. One other housekeeping item, it did come to our attention that there are maybe some calendar invitations that are like ghost calendar invitations. Sometimes Google is too smart and holds on to things that have been canceled. If you are wondering about what's going on in your calendar, please come talk to us. The next time this group will come together is July 28th. Okay, so July 28th is the joint meeting that both groups will come together for. So just wanted to reorient just make sure calendars look the way they should. And the last housekeeping item that's not really housekeeping, but is a just thing I didn't want to forget to say is the vacancy that you'll see around the table. There is a vacancy in this group at this moment. Adam Horst did take a job out west from, I think he's at Stanford. So we congratulated him and he's moving on with his family, but just wanted to make folks aware that that process of inviting applications and nominations is ongoing. That sits with the Commissioner of Health. So you will have a new member sitting around the table before the joint meeting. If you have questions about that, very happy to talk more about that process, but just wanted to acknowledge that vacancy is there. Just a reminder that the meeting is being recorded. If you would rather come sit outside of the recording space, you're welcome to move your chairs up here. Closed captioning is available. The recording will be available online. And please do email us at health.affordability@state.mn.us if you're listening in and you want to be weighing in, or if you have tech problems. We'd love to hear from you. Okay. Yes. So thank you for clarifying. We are changing the time. 9 to 3 is a long meeting. 9 to 1 should be what is showing up now. And I'm looking around to confirm. I think that we've edited that. That's what I'm saying. It's like these calendars, they remember things. So 9 to 1 is what you should see on there. We will reiterate that both in the written material, the slides that you have, and we'll send out emails about that so that hopefully you can check that's reflective on your calendar. Thank you, Amy, for checking. Okay, where we've been, where we're going. I'm going to quickly move through the pre-read materials, just assuming that you've spent some time with those. There's a lot of just words about where we've been. I'm not going to walk through every single one of those, but what I do want to do at this time is just reorient the group to what has happened over the last 8 months that the Healthcare Affordability Advisory Task Force has been together and that this group got together in January. We're also going to invite all of our co-chairs to just weigh in a little bit and help this group see where the opportunity is for the conversation. So first, I will just jump through and then I'll turn to Sheila and Matt online and then to Gita and Joel. So just as a reminder, we have these two task forces. What are their roles? The Healthcare Affordability Advisory Task Force is slated to be the consumer purchaser, non-healthcare leader group that is making policy recommendations to the center, to MDH. They're not going to the legislature, they're going to the Department of Health, all in service of making healthcare more affordable for Minnesota. Their job is also to analyze spending trends, look at cost drivers, and we've started some of that, but really need to dig further in, and that's what we'd like to get some guidance on today. The Provider Payer Advisory Task Force is a really important consultative partner to the Healthcare Affordability Advisory Task Force. So this group's job is to offer insights, What's feasible? What is it going to look like to do this work? How would you think about the research questions? Where are the pitfalls? Where have we tried this? It hasn't worked. That is really where we want to hear this group shaping the conversation. This group really has the technical expertise. So this may be very obvious to you, but I just really wanted to distinguish the two groups and just where you can best weigh in and shape the conversation. Also, as a reminder, you haven't seen these images before, but you've seen the content. How are we talking about affordability? We've talked about it in terms of a couple of different things, including the principles and values that this group has weighed in on with the Healthcare Affordability Advisory Task Force. We've also talked about it in terms of both the individual's experience. So that's what's on the right. We know that as many as a quarter of Minnesotans, probably more, are reporting, I'm skipping my drugs, I'm splitting my pills, I'm skipping screening, my deductible is too high, I don't want to go in for care. Like we all know the story. That is something that we orient to say, this is how we're going to know if we are moving the needle on healthcare affordability. But we're also looking at it from a systems perspective. This group has said alongside the Healthcare Affordability Advisory Task Force, it is not enough to just shift costs around. And really, we want to be looking at the total healthcare spending in the state and the fact that it is growing at a rate that is faster than wages, faster than pretty much any economic trend we look at. So again, you've seen it before, but I wanted to reorient us back to some of those original conversations about how to talk about affordability and what are we really seeking. I won't talk through all of these, but you have in your pre-reads just two illustrations of the timelines to date, like what has happened. The two task forces have been working back and forth to identify some initial topic areas for future policy development and future research. And so far, those have really landed on those 4 topics identified in that kind of December through March period. So that's non-value added spending, high and variable prices, and value-based payment and insurance design. So we've talked about all those topics. And so what you've seen today and where we're really going to spend time on kind of individual topics, they've all emerged from those areas. What's not here is there's plenty of other topic areas that both the center and this task force and the Healthcare Affordability Advisory Task Force may come back to. I just wanted to orient you to where these came from. So like these are those 4 buckets of where the task force has been really spending its time finding where are going to be the priority options, the priority kind of research questions that they want to pursue. And we've been going through between the two task forces to invite feedback, to ask kind of technical questions. So again, I won't go through all this, but I just wanted to reorient you to where we've been and why the priorities look the way that they do. Since you all got together last, the Healthcare Affordability Advisory Task Force has met twice and have been prioritizing within those topic areas. So again, non-value added spending and high variable prices, that's really where they've spent a lot of time thinking about what could be the next research questions within that. There's been discussion with this group and with the Healthcare Affordability Advisory Task Force of insurance benefit design. How do we better design products and simplify health insurance products in a way that steers consumers towards high value care and value-based payment, moving away from fee-for-service. Those have both been topics of the session. We have not seen real emergent topic areas sort of emerge from that. And so there haven't been a lot of kind of specific options emerge yet. And so you'll see that reflected in the materials. There's been some discussion of regrounding of the Healthcare Affordability Advisory Task Force, regrounding as well. And today there's 7 potential priorities. That's kind of a long list. And so this group's job is now to help kind of refine those. And I will be listening for also where should the Healthcare Affordability Advisory Task Force start? Because that's a lot of things. It's not helpful, I think, to kind of spread the groups too thin. So how would you recommend we start? Just a note that wording is evolving. And so like this is the 7 things, the 7 bullets that we'll look through later in today's agenda. But again, the wording you'll see sort of reflected a little bit differently throughout. You also have in front of you 2 other pre-reads that we wanted you to see what the Healthcare Affordability Advisory Task Force has seen about these topics. So I hope you had a chance to look through those. We won't be walking through those in detail, but they just give you another just a little more color as to what we are talking about, what the healthcare affordability is talking about, what we have been researching around these topic areas. With that, I will pause. I also, sorry, I want to note that we have been additionally doing some stakeholder engagement, including with legislators, the Commissioner of Health, and with members of the public, with consumer advocates on these topic areas. I don't know if this group has had a chance to look at their email and see what we sent out yesterday, which is a summary of that for this conversation that happened on May 20th. We had a public virtual conversation with as many as 50 some consumer advocates ranging from across the state, ranging from, independent pharmacists, Academy of Family Physicians, but also, union representatives, disease groups. So it's a wide range of folks. I welcome you to take a look at that summary. But what we basically heard when we asked them, where do you see opportunity in these topics? Are they aligned with the work that you are doing? They basically said, these match what we want to be doing too. This is feeling on the right track. There's certainly some sort of ordering and sequencing that they've recommended, so we encourage you to take a look at that. But we did see a lot of kind of feedback saying like, yes, this feels like the right track to be on, and that these are really interconnected issues. And so how do we think about the root causes of them? You'll see some quotes from the group in your materials. We encourage you to take a look at those just to see the richness of the discussion. But again, wanted mostly you to know that we're talking about these publicly, and we're getting some feedback from others beyond this group and the Healthcare Affordability Advisory Task Force. So this is where I'm going to pause. So what's next? We're having the Healthcare Affordability Advisory Task Force come back together at the end of this month. They will be putting their summary priority topic area, this is what we'd like to see next in the form, in writing to MDH as a letter to the commissioner. And so our co-chair is really authoring that. And this opportunity today is to just help shape that. You will have an opportunity to come back together at the joint meeting in July 28th, back in this room, to have all of the task force members together to hash out what the future work will look like within those topic areas. So that's what's coming next. I want to pause here, and I'd like to start opening up for discussion, but first want to start with some comments from our co-chairs to just, again, reorient the group to what is most helpful. And Sheila, was thinking I'd start with you, and then Matt, if you wanted to add to that, we'll go from there. Sheila, take it away.
There's the button. There it is. Okay. Is it on? Okay.
Yes.
Well, I'm glad to be with you. And I know that Matt is listening in as well. Our intention is to always be here listening in so that we are able to carry forward what the input that you have, in addition to how the staff analyze what you, if we want to have these dialogues and these conversations. But at I think it was probably the May task force meeting I attended, we had a conversation about what's our role. And, the word task force, we all have a mental frame of what a task force is. And it took me some time being part of this group to understand the role of this task force. And so I commented on it at our meeting and was asked to come and comment to you as well. And I think Matt's going to join the conversation. So when you say task force to me, I have been on so many healthcare task forces in the last 25 years, and I have an automatic assumption of what that means. It means we're going to meet, we're going to look at some things, we're going to make a recommendation, we're going to send a report, we're done. And most of the time, our task force reports sit on a shelf someplace, and once in a while, they're used. If we have a really strong support for the task force recommendations, then others will carry it forward to the legislature, to their organizations, so on. Well, I think some of that will still happen here, but what we're about is different than a typical task force ask that the legislature has created. Instead, we are advisors to creating a healthcare affordability center at the Department of Health. And as I think about that, I think we are now have an opportunity that's very unique, which is to create a center that will live beyond the life of a task force, that will become part of the establishment in Minnesota, that will become a leading place for doing deep research, deep thinking about healthcare affordability. And, Minnesota has led in the healthcare arena in many ways over the years. And the more I think about this, I think this is another way that we're attempting to lead. We know that healthcare affordability is critical for our residents. It's critical for our businesses. It's critical for employers. And we also know that there's now that this is an ongoing problem. It is, there's different nuances every time, but there's always, this is an issue that is not going to go away. And so can we as a state of Minnesota have a thoughtful approach to really looking at what are the drivers of healthcare affordability for our residents? And can we do the deep thinking, the deep research in consultation with with these two task forces? And with the broader community. So when you look at how this is set up, it's really kind of unique because we have the healthcare affordability task force, we have the provider payer task force, and then there's the community engagement. And I went to the community engagement meeting as well. And we are then thereby creating, I believe we're at the table to create a deeper dialogue, a deeper look, and a commitment to creating an ongoing capacity in Minnesota that we're part of, but that will live with staff resources within the Department of Health. And so I think I think if you can, I get triggered by the word task force because that applies to me short-term, deep dive, quick recommendations. Thank you very much. You're done. And we all agreed to serve for 2 years, but our 2 years is intended to be to get this things launched, to get it on very solid footing, and to be able to carry forward. And I'm anticipating that some of us will stay with us longer than the 2 years we've committed to so far. This isn't very often that you are asked to serve on a task force for 2 years. So that in itself is a sign that there's an intention to invest the staff resources and the capacity and the advice from advisors to create a really strong center. And we're part of creating that center. So that's how I've come to think about it. And Matt, are you with us? Do you want to make some comments?
Good morning, everyone. I'm here. I don't have really anything to add other than the center has an opportunity to play an influential role, and we have the opportunity to help guide it without necessarily directing it. And I think that's what our work is, and really look forward to both task forces' input in that activity.
Yeah, I think that's really well stated. We're attempt to guide and create something that's durable, that will help Minnesota over the years. And my ambition now is that we become, nationally known for the quality of our healthcare affordability center. I think we have the capacity to do that in Minnesota with those of you around, well, all of us around the table, and with the staff willingness to really deeply listen and take guidance. That's unusual. There's not an esoteric group in an academic setting, no offense, Matt, coming forward with their recommendations. This is really integrating research with real life experience, with the consumer experience, and with the community's input to creating a center. So I think we're in a unique position, and I'm more excited than I was a few months ago about this. So thank you.
Matt and Sheila, thank you. And I also just want to thank Geeta and Joel for jumping in with us to help facilitate that. Because as Sheila and Matt are pointing out, it may not feel like other task forces that this group has been on. So I wanted to turn to both Joel and Geeta and just see if there's anything you would like to add as to like how you would like to see this group functioning, and anything you'd like to add it just as you step in as co-chairs.
There's a little button under the white thing right here at the top, the white strip at the top. For all of you to know, there's a white, I just learned there's a white strip.
I'm too short to see the top. To me, that was hearing Sheila and Matt at the last broad task force meeting was comforting, because I was confused about the role, and listening to the people there talk about everything possible that could be driving the cost seemed like we were going in a circle attending the last two meetings. And then when Sheila and Matt talked about the actual role and giving advice to the health department on the kind of reports and information that would be helpful so that we would be fact-based instead of sitting in our bubbles with opinions about what we know from our own work, was enlightening in a sense that I felt like there was actually a really important role for this group to be providing. And at least I think Joel and I heard from those at the table that they appreciated the feedback that they were getting from this group, because they tend to be big thinkers. And we're living down in the weeds of what's actually happening daily. And so there was great appreciation that I think we appreciated hearing, but also it really helped understanding the advisory role we have, because I'm not sure it was clear here.
Agreed, Gita. I think the question of, because I had asked that question of Alex, what is our role? Are we independent? Are we subservient to? And I think we've gotten some clarity, and today's agenda is a good example of that. They're asking for our technical advice. I'd say one thing that I've observed is our role as co-chairs is evolving. So it's something that I think we'll figure out over the course of the next meeting or two. And we are actually meeting with Sheila and Matt, I think it's next week, to try to put a little more form and function maybe around that. One of the things I'm excited about with this group is its name, Payer and Providers Coming Together. And too many times, from the provider perspective, it feels like it's an adversarial relationship. And it would be great, I think, if I had a dream coming out of this, is what can we find as common ground as payer and provider and say, we all know that this is the wasteful spending, or this is something that's not working, or here's something that can work. And, if we can come up with a couple of great things in our advice to the Healthcare Advisory Task Force, or quite honestly, even in something that's not on the radar at this moment, that can help find that value, that would be exciting for me as an outcome.
Yeah, Joel, I want to just highlight something you mentioned, which is this group's consultative role, providing shape to the Healthcare Affordability Advisory Task Force priorities, and also inviting this group to, there may be things that may not be on that group's radar, right? And so I just want to invite that. It doesn't mean sort of, that there's going to be opportunities to spend sort of time in this meeting to do things that the Healthcare Affordability Advisory Task Force isn't really talking about. Like, it doesn't make sense to me to have sort of two parallel paths going, but it does not mean that this group shouldn't offer, hey, how has this group kind of thought about broadening this topic to include blank? So I wanted to just reiterate that I think that is in scope of this group to be thinking about. What questions do people have about role and what is most helpful at this time in terms of discussion before we actually get into the content?
I'll start if that's okay. Lynn Nelson from Blue Cross. Sheila, thank you, and Matt for that clarification. I think that's really helpful. I've seen many task force in my time as well. And to think of it as longer term, bigger picture, and setting up the Center for Healthcare Affordability to be have a win in the long term. I think it's really important, and to be successful in the long term and not just a short term thing. And then Guido and Joel, I both appreciate your perspective about Joel. I also want payers and providers to come together. We have a common goal of meeting Minnesota's needs across all 87 counties. And I think it would serve us well to have common goals and work towards them in this environment that we're in, because it's moving quickly. We can't keep at the pace we are of spending on healthcare, whether it's in Medicaid, which is at a 19% growth rate, which is unsustainable in this period of time, and the cost shift that's going on to the commercial market. So I really appreciate this group and coming together, and I hope the gang stays together long after our appointments to continue the conversation.
Mallory, would you turn the mic on if it's not on? Maybe turn it a little closer. Might not be. Do you see the little button up top? Yep. Should. Okay. Sorry to pick on you. Mind Sean giving yours over. Thank you.
How's that?
That
Oh,
is-
that is definitely working. Okay, great. Mallory Kushel, Alina Health, appreciate the context setting, and thank you both. Gratitude for serving as co-chairs. Your comment also just had me thinking about the scope of the task force, especially as we think about the goal to be longer term and have broader impact. And I know initially we had talked about really focusing on the commercial market, and your comments around Medicaid expansion, I think is worth additional discussion as we think about longer term scope and if we can have the intended impact with a narrowly focused scope on the commercial market. So that would be a question to take back probably to the larger group. Oh, you can.
Is it on?
Yes.
Okay. Hi, Aaron Blomquist, Ridgeview Medical Center. I had the same reaction, I guess, when Medicaid was brought up, because I thought we weren't really here to talk about that and the cost shift. And your slide 12 had a bullet point around health insurance affordability. And I guess I thought commercial health insurance affordability was what our goal was. And now I guess I'm wondering if it's broader than that. Are we talking about, uninsured? Does it go beyond just employer sponsored care? So it would be helpful to understand that. And right, your North Stars here were more broad as well. But again, I'm just trying to think about the effort of this group, and perhaps other groups have a broader goal in mind.
No, I'll quickly address that, Aaron. And I hear the question about, is it commercial? Is it like all of these are on the table? And I recognize I may have inadvertently confused people by saying we're starting with commercial market. I don't think that's quite the way that we need to be talking about this. So I have been reflecting on how to talk about this. I think what we have seen across the nation is that other states are just have more sort of control within the commercial market, and because there are just more significant fluctuations and affordability burdens on people who are trying to buy health insurance on the individual marketplace, they're seeing their employer premiums go up every year, their deductibles, cost sharing, et cetera. And so that's where that comment came from. Can this group talk about the whole of healthcare spending? We should, right? It would be a real miss if we did not talk about public spending, or if we didn't talk about uninsured individuals in Minnesota. In Minnesota, are people churning on and off? That population of uninsured will change really significantly with HR 1. And so I just wanted to bring this back up because I know it's a little like heady. It's like, well, what does this mean? Like, where do we then focus the work? I want us to kind of hold this large North Star in the back of our minds, because it means that all of it is on the table. But again, this discussion today, I hope will be reflecting on what the Healthcare Affordability Advisory Task Force has started to name as potential priority areas. And it's not sort of, I hope it doesn't appear that those are limited to one part of the market. They're not intended to be.
Lynn Nelson, Blue Cross, I have a follow-up question. How many other centers for healthcare affordability are there around the nation? And because I'm kind of competitive, so I'd really like us to be the best. And I'm just curious.
Here's some some hopefully inspiring news. We are one of many, but we are a decade behind. So I just came from a meeting with, let's say, maybe a dozen other states: Oregon, Massachusetts, Connecticut. All of us, they have some really significant sort of thinking happening in a very focused way that I think we can learn a lot from. So I'll put it that way. Thanks for asking. I love that. Thanks for the discussion and for the co-chairs commenting. And we're going to go ahead and jump in with some discussion of the priority topics and invite our co-chairs as well to come back and just speak about some of those.
Hey, good morning, everyone. What a great conversation so far. I love hearing all the optimism and excitement in the room. And yeah, I think we have an opportunity today to have a really good conversation. I've already made a couple notes of like big picture things for us to highlight back for the Healthcare Affordability Advisory Task Force when they come together again in late June. And I'm sure I will have many more. So Alex already talked about this a little bit, but we shared with you all, and we're not going to talk through this in detail, but one of the pre-reads was the potential topic tracker. And it's a sheet and it's got some rows highlighted in green. What we wanted you to see was we wanted to make sure that you're fully informed about the path that the Healthcare Affordability Task Force has taken to get where it is today. So back in February, we did kind of a like a sticky, brainstorming exercise with sticky notes on like big pieces of paper to just like get all the ideas out on the table. The big list here is the result of that exercise. There was a lot of ideas and we combined things that were really similar, but this was the result of that exercise. So when we came back together with that group in April, what we did was said, okay, here's all the things that are on the table. And we wanted to get a sense of which of those ideas had the most momentum and interest behind them. So we did some live polling exercises, and the things that you see highlighted in green on this sheet are the things that emerged from that meeting as the topics that have the most momentum and interest from that task force. So, but we wanted you to see the full list. So the first page of it actually is the things that voting is not the right, is the things that people indicated highest interest in that meeting. The second page is sort of the list of other things that emerged from that big sticky note exercise that we didn't actually like include in the live polling exercise. We had a conversation where we had an opportunities for people to say, no, I think that one's really important. Let's pull it forward into the polling exercise. But just they're here for completeness because we want you to see and have access to all of that information. So that's what that was. And talking about the rows that were highlighted in green, those are the 5 things that we are going to spend most of our time today talking about. The other thing that was in the pre-reads was the other set of information that we shared with the Affordability Advisory Task Force, the context that we brought to them for consideration when they were thinking about like, okay, now what do we do with these 5 topics? So it includes, it's kind of a setup about like, well, why does this matter? What's the current context? So like what's going on in Minnesota that the task force should be aware of, because we want to not duplicate other things that are going on. And we just kind of want to be aware of things that might conflict with it. What would the task force need to learn was the third area. And then some initial thinking about like, what would pursuing this area look like for the task force or for the center? So those are the pieces of context on each of the 5 topics that we brought to the Affordability Advisory Task Force. We are not planning to go through this in detail today, but it's for context for you. And like, if people want to raise specific things from or surface specific things from that material, we wanted to make sure that everyone has access to it. And we have it in front of us and we can turn to it if we need to. So we have 3 goals for this part of the discussion, and we are going to split it up. So we've got the 5 topics. We actually have topics 6 and 7, which are the insurance benefit design and value-based payment, which the affordability task, this group has talked about before, number 1. And the Affordability Task Force has not really had a lot of opportunity to get really deep on those, as Alex shared with you. So those are also on the table for today. We are planning to spend most of our time on the 5 topics that this group has not yet talked about. We originally planned, I think, well, we're planning on a break at 10:30. So We might be able to get through 2 of them before 10:30. Let's kind of just see how it goes. So the 3 things, oops, sorry. The 3 things, we would like your perspective and reflections on how we have framed these topics for the affordability task force. And like, if you have other things to raise about, like, what are the things that are important for them to be thinking about? That this is a really important time for this input to come in, as they are kind of like finalizing their first round of input to the Commissioner of Health on what the priorities should be. What's your advice about where to start? So some of these are more complex than others, but they're all probably like have a significant level of complexity to them. But where do you think it's most important to start? Where are the opportunities most significant? What are the greatest potential pitfalls of the various topics that are on the table? And then we're looking to you all to share your perspective on kind of like the broader questions that these are raising for the Affordability Task Force members. We do also, I should mention, after the last Affordability Task Force meeting a couple of weeks ago, 2 or 3 weeks ago, we did kind of a survey with them to also just ask them, like, what do you want to ask? What do you want us to ask the payer provider task force on your behalf? And so we have like a specific section where we will be like making sure that if we don't get to those questions as part of our broader conversation, that we will have the opportunity to like specifically pose those questions and make sure that we bring back information about them. So any questions so far? Okay, perfect. So like I said, we are going to go through the topics one by one, just to make sure that we don't get all excited about one of the topics and spend 80% of our time on that and 20% on the other 4. So the first one is the impact of ownership structure and profit-driven intermediaries. Also want to re-emphasize that the wording of how we've been talking about these has been evolving over time. It is continuing to evolve. So what you see on this piece of paper is going to be different than you saw on the piece of paper with the green rows highlighted, for example. That's why, as the Affordability Task Force has had discussions, we've also had a lot of discussion about how to describe what these things are, while being like, without jumping, for example, right away to, we should regulate healthcare markets. Well, first, the question is, what is the problem that we're trying to solve? What do we need to learn about that problem? And what are the possible solutions? So I just wanted to point out for you that some of the wording is a little bit different, but the topic really is about how ownership structures like private equity and other profit-driven intermediaries are affecting healthcare spending, and what are some of the options to reduce or prevent negative impacts on affordability. And we're going to ask you these same questions about each of the 5 topics. So from your perspective, what does the Affordability Task Force need to learn about this topic as it moves forward? What are some potential pathways to address this topic? What is important to consider from a Minnesota specific context? And I think that's a place where this group really has important perspective to add, because you sort of like live every day in this, like we are comparing ourselves to other states, but also know that there are a lot of unique things in Minnesota. So we have some advantages, we have some disadvantages. Alex, when you talked about how we're a decade behind, part of me was like, but not really, because we had the health economics program before anyone. So we actually are starting with a much stronger data infrastructure that some of the states who have stood up these kinds of efforts in the last decade did not have. So we're not, I hope we're not as far behind as we could have been. And then what's your advice about how to proceed with considering this topic as the work of the center and the work of the task forces move forward? So that is our charge. So on the first, I'm gonna back up the slide so that we all can like be thinking about like what is the wording of the topic as we're having the conversation. So first topic is ownership structure and profit-driven intermediaries. Lynn, did you want to start?
And
Oh,
I was
go
going
ahead.
to ask if for each of these, we were going to invite our co-chairs to
Oh, thank
just
you.
comment a little bit on how they've been thinking about these. We've asked them to do a little bit of extra, just thinking about those. Do you want to start, Joel and Gita, kick off the conversation, and then would love to hear from Lynn.
Sure. So again, and Gita and I have had the opportunity to sit in on the Healthcare Advisory Task Force meetings, observing, not participating, but at least we're getting to hear some of the inner discussions that are happening. As I look at this, I made a note from one of the meetings. I don't think it's anywhere in the materials, but the word undesirable came up in terms of undesirable ownership structures. Well, my first thought is, well, who defines that? I would say as a rural healthcare provider running a community health system, an undesirable provider may be an independent imaging center or ambulatory surgery center who is taking away potentially profitable business that's covering overhead in my critical access environment. And if you do the math on all that, it actually increases the total cost because Medicare is paying the infrastructure that I have for overhead and claims are being paid then to a separate provider. But I think it's never a clean answer. I think a question of which of these ownership structures are creating value? Which ones are not creating value or preventing problems? Some of the research we've gotten was that. How does it all tie then if it becomes a purchaser, whether that's an employer, pricing group, or the TPA's insurers saying, well, we're going to go to the lowest common price denominator, and that's what we're going to pay, reference pricing concept. Well, how do we transition that for the providers who maybe aren't in that environment and set the rules such that at least everybody has the opportunity to play? And I start to look at this and I couldn't help but think, listening into the last two meetings, is it starts to sound a little like, do we need to, I'm almost ashamed to say that I'm saying this, or surprised that it starts to smack of health planning and critical or a certificate of need kind of questions. Do we need all of that structure? And I think that would be a hard place to go back to. I'm actually going to look at the secondary comment here about profit-driven intermediaries, and I think this ties a lot back to work that we've already discussed and talked about, especially on the revenue cycle side. There's so much complexity in the system, and one of the pre-read topics was all of those things that probably both payers and providers are spending money on because of that complexity. And can we find those opportunities again as partners in this to avoid some of that waste?
While it was enlightening to listen to the bigger task force conversation, one of the things that is a balance in this is whether rural locations can survive without some type of consolidation or ownership changes. So we listened to a lot of debate about the value of keeping something local or having women have to go 60 miles to be able to deliver a baby, and having that balance in there, because we needed to see better information about the different structures that exist or could exist for ownership. And it seemed like people didn't have all the education needed to have a thoughtful conversation.
All right, Amy McNally, provider. So I think a couple things come to mind with comments that have been made about this. Consolidation, I'm a private practice oncologist, surgeon, and prescribed chemo. So we're the only community-based private practice, not private equity owned oncology group left in the state. So when I hear the term consolidation, what things come to mind for us? I am not trying to pretend that our practice, like any 5, 10, 15 years ago, had value-based care incentives and goals in our conversations, right? The game has changed, but it always drives to the why. Why are we consolidating? Like, what is driving the need to consolidate? And one thing I believe in, and I know that my colleagues do, is to keep care in the community closest to the patients. And they should be able to get the top quality care as close to home as possible, whether that be primary care all the way to the continuum of cancer, the more complex things like cancer care. Because not only if cost of care goes up, do patients not get treatment or comply with the recommended treatment, even if they live 2 minutes from MD Anderson in Texas, these big centers. But if you don't have it close to home and it's convenient and we're busy and we have jobs and families, we don't go. We don't get our screening. We don't go to the doctor. We can't take off time to drive 2 hours to go get a chemotherapy treatment, right? So it's not just a financial thing, it's a reality thing for our patients all over the state of Minnesota. So consolidation could be seen as just vanishing access to care, period, doesn't matter, primary to cancer. But then consolidation to me also means, I'm going to go back to that, what is driving it? What's driving it is not wanting to not be in the communities. It's the economics of healthcare that is driving consolidation. And the economics of healthcare, I don't blame large hospital systems. I don't blame private practice physicians who choose private equity necessarily, because we're all trying to just stay alive and survive and keep our doors open. But we're incentivized to play this game, right? So in my world, 340B has incentivized hospital systems to consolidate to have cancer programs. Reality, right? That has been a game changer for our practice since 2019, where healthcare systems need oncology to make money to keep their doors open. That's just a fact, right? That doesn't incentivize hospital care systems to then do value-based care in oncology. Our practice has done value-based care in oncology because that's how we survive. We don't have, it's not an even playing field. We don't have access to 340B, right? So you have to start, that's just an example. So you have to start asking, in my opinion, what's driving the consolidation? For private practice docs, I know a ton of them because we're in a small community. We're a vanishing group of physicians in the state of Minnesota. But some of them are choosing private equity because they don't want to become part of the healthcare system, right? Because that's what they're trying to avoid. But I don't know if they understand the pitfalls of it, right? No longer are you a shareholder. The shareholders making the decisions are just making decisions based on dividends and getting a paycheck, not what's right for your clinic, not what's right for your staff, not what's right for your patients, right? So, but I understand they're trying to find a way to survive without getting consolidated, right? So what is incentivizing it? And then I would ask, before I stop talking, sorry, I could do this forever, is then the question is how do you de-incentivize that or even the playing field? Or like, we have to answer the why, or otherwise we can't do the rest of the four. We can't answer what to do next, right? We have to understand what are those levers, what are those incentives that have caused this shift in healthcare to then be able to better understand it.
Fantastic. That's exactly the kind of insight that we're looking for. So keep it coming. Lynn.
Yeah, Lynn from Blue Cross here. And going back to being behind on the Center for Affordability, Amy said, if anybody watched the Knicks last night and their comeback, that's what we're going to do. So I didn't want to lose that because I'm like, you say that. But I appreciate your comments. And I think looking into this private equity issue is really important to look at the incentives and motives behind it. And, we saw this, and we're seeing this in the No Surprises implementation and independent dispute resolution Act. And, 3 private equity firms that did not exist, or 3 firms that didn't exist, private equity, before the No Surprises Act enforcement went into place, and an independent dispute resolution, and they are making billions of dollars. One couple made $1.5 billion on this process. And that's just increasing prices, the underlying prices, and the impact on affordability and the impact on premiums. We don't have as much of a problem here in Minnesota because we don't have as much for-profit now. But we're watching this on a national level and trying to make some changes at a national level of looking into this further to have more oversight of these entities. Now, to bring it into Minnesota, I think there's great concern of a couple entities that are or industries that are moving to private equity. And we're seeing some of that movement where they want, unlimited, a mandate for unlimited benefit under the commercial rate, where they could go to a waiver for Medicaid. And they want that commercial rate to pad their bottom lines because they're a lot moving to private equity. And so again, that's impacting the commercial rate on trying to make sure there's a mandate in place to pay that. And the other concern I have that is, really relevant right now is the revalidation of providers from DHS, and many of those providers not being validated and concerned about making payroll. It's right for private equity, pick them up right now and say, we can help you with that payroll right now. And they're weeks to months away from losing that payroll. So I'm very concerned about this happening at this very minute with those providers that are not being validated. So I think it's really something we need to look into more about what's happening in that space, how much movement is happening right now, and how much it's going to impact the underlying cost, which then impacts premiums.
Thanks. Tyler?
This is probably not a helpful comment, but I can't not say it. So I think one of the questions this brings up for me are like, we've had profit driven, maybe not a huge focus on value among healthcare oriented companies for years. And so in private equity, sort of like the most egregious of like that continuum. So sort of like focusing on private equity in particular, sort of like just feels sort of like putting a line in the sand of like along a continuum of like markets. And so like in this priority seems embedded in a larger question, which is like, what kind of market are we talking about? Should we think about healthcare? So as we try to help the center achieve its vision and mission of high quality care that is affordable, should we be operating under the rubric of thinking about healthcare more like our schools and our roads, or as malls and movie theaters? And I think some consensus around how we think about healthcare then helps us make decisions like this. So I don't know like where that fits, but that's just like floating around in my mind is a lot of these questions sort of, it depends. Like what do we want? Like, what do we think is the optimal way to, like, what kind of market will best foster that mission? And then the second thing I would just say is, value is in the mission statement of the center, but I also think it's important to include it in these priority topics. So there are going to be ways to improve affordability, but I think in every one of these, we need to do it making sure that at minimum, it doesn't harm healthcare outcomes, and being really clear about that in each of these priority areas, that like, yes, we want to make care more affordable and we still want it to be good healthcare.
Kevin. Oh, sorry, Kate. Sorry about that.
I was just going to say that my name is Kate. I'm a physician. This came up about 2 years ago as part of the family physicians in Minnesota, and across the board in primary care, Minnesota family physicians strongly opposed private equity involvement in any aspect of primary care, for the concerns that have sort of already been voiced of like, we've seen it in other national structures where it essentially cannibalized practices in order to make a profit, and patients really suffered. And as a result of that, then like clinicians and providers suffered as well. And to Tyler's point, I think part of the reason that we saw it that way is that I'm making a broad generalization here, but we tend to see healthcare as like a common good rather than a business to operate, and understanding that like you still need to meet a budget and things like that. But I think that's one of the reasons that we push back against
profit drive as a motive within healthcare. And one of the reasons that's how we approach cost containment as well.
Yeah, good morning. This is Kevin. I don't know many answers here, but just a few questions I might think about here. Where is this happening? How much? What's the growth rate of this? I don't know. I mean, I think you could understand through the 990s of the hospitals, those relationships, but I think there's a lot going on outside of that that I think you'd want just to get some really good data on. A couple other questions like for what purpose? Why are they in the market? What's their mission? What's their targeted population to serve? I mean, if they're really narrowly focused on a commercial population, is that helping or hurting the healthcare infrastructure since all of these things are interrelated? And then just one thing to consider is, there probably are going to be times that the innovation or efficiency gained by having an investment in something could be helpful to the healthcare ecosystem. But does that outweigh the profit incentive and the other sort of externalities that come along with that relationship? So it's complex. I think it's a really good topic to explore. Thanks.
Ellie, thank you. Yep, so is Cassandra, are there others online at the moment? Let's take a moment and I'll call on Cassandra next, but invite any other task force members who might be online to also jump in as well.
Thanks. I'm just going to piggyback on that last comment. I don't know that we have like an annual disclosure process to understand who has private equity investment in patient care. And so understanding what's happened to spending. Sorry, I'm getting feedback. What has happened to spending before and after any private equity investment would be really important to know.
Do we still have the meet? We actually still have the meet. I'm sorry about the sound issues. Sound like that was just in the online meeting room, but we're trying to fix it.
Yeah, Cassandra, we can hear you well in the room, but I understand there's an echo on the phone, so we're working on that.
Okay. I'll put my other comment in the chat. Actually, I think now that you've muted yourself, it might be better. My other comment would be to understand how and who is using the hospital price transparency info and what impact that is having on rising costs. There is some evidence that suggests that both payers and providers are using tools that have been developed by private equity to influence their pricing strategies. But patients are not using this, and it was intended to be used by patients to understand where their healthcare costs could be mitigated or what the cost would be at their preferred provider. And so when you think about antitrust, that transparency tool is not being used as it's intended. Thank you.
Thank you. Geeta.
As the different topics and reports are being put together, something that seems to be underlying from a lot of the questions that people are raising here is having a column that shows if there's a quality outcome impact that would occur or access from it, that it needs to be on there. And I know in the first meetings we talked about, we're focused on the cost trajectory, but if we don't have that column there with it, I think we're going to lose what the health department's really trying to get out of all of this.
Thanks. Mallory.
Yeah, I would echo everything we've heard thus far, especially the questions down here to consider. So really understanding the current landscape, it's not something I'm clear on. What and where and who are the private equity owned healthcare organizations in Minnesota or for profit. To your point, there's a continuum there. So how do we really understand that and understand the impact that is having on affordability of healthcare across the state? I think Joel's questions and comments I appreciate too. Where could and how can this be detrimental to health systems and hospitals in rural areas, but also where could it help? Where could we be providing care where we otherwise may not have care across the state? And so I think really understanding, both aspects of the model would be important. And then really maybe understanding how we defined value of care and private equity. And again, kind of understanding the full spectrum where again, to the point where could innovation and providing care where we don't have it today benefit healthcare costs and affordability across the state, as opposed to really impede or impacting it. And then maybe my last question is kind of the big question is, do we understand the benefits of care regardless of the ownership structure versus no care and how that impacts cost?
Thanks. Sean, go ahead.
Thanks, Sean Frost from Health Partners, representing the health insurance plan. I feel like I need to make a very specific comment about virtual care and digital healthcare. It seems like that segment of the healthcare industry has exploded in the past couple of years here. And it feels to me, not having done any research on this, so this is anecdotal, but it feels to me as though the ownership of those entities in healthcare is disproportionately private equity. And the other complexity that poses is they're being integrated into historical longstanding methods of delivering care. So, they're being bolted on to traditional clinics and multi-specialty healthcare systems. And so untangling what within a single system is owned by private equity versus owned by the system itself seems complex to me too, and perhaps important if it is true that disproportionately that evolving segment of healthcare is now being driven and run by private equity. And I want to go back to what Joel started out with as well, because that really resonated with me, and I consistently appreciate you bringing up the interests of rural healthcare. What I thought about, though, to perhaps make your comments a little bit more broad is in regard to who defines what is the right ownership structure. Segmenting the healthcare industry specific to Minnesota, because there's uniquenesses in Minnesota compared to other places in the country, right? Into segments that would help us better define that and understand that may be important. You started with rural versus urban, but there may be some other ways to think about that. Multi-specialty, large healthcare systems versus independence. That's a theme that's been brought up here a couple of times. And perhaps even virtual care versus traditional in-person bricks and mortar delivered care. So that exercise perhaps could be helpful in order to figure that out, but that was exceptionally important, I think, what you called out at the outset.
Yeah, can we dig in a little bit more to some of the Minnesota specific factors that we should be bringing to the table and understanding, like all of you are telling us, yeah, we don't have the data, we don't have that. Yep, we know that too, but like, what do we need? But what do we already know about some of the ways that the characteristics in Minnesota are different that are either going to protect us or make us more vulnerable to some of the impacts that we're worried about? Joel.
Sean, I appreciate your comments. And one of the things, and probably I was going to bring this up later in the meeting, I have a hard time separating the ownership structure question here from market consolidation that we're going to talk about later. Because in the end, it's an ownership question and a structural design question. So I do think we may want to consider, do we attempt to package those together? And maybe the private equity question has come up a few times here is, we as providers and payer community, I believe, are participating in that based on the contracts that we have for some of the revenue cycle optimization systems that we've got, because those are the people playing in that market, and they're probably bringing good innovation that might bring value, but there's a lot of money going into that and a lot of profit going into that. That is, it used to be sitting in either the payer provider wheelhouse that we were just doing internally. And again, because of the complexity or because of lack of access to the right staff or cost of technology, we've had to outsource that. And I believe that's just adding cost into the total system.
Mallory, go ahead.
Yeah, I guess I do have a thought on that. I as a leader in a nonprofit healthcare system, I do see number 3 and number 1 as quite different. I think paying shareholders with profits versus reinvesting in the community with profits are 2 different ways to evaluate cost of care. So I guess I'd like to just say that to me, it makes sense that they're separate, and I hear what you're saying. I've got other comments I'll add for number 3 around what I think systems offer in terms of care, but that was important I think for me to say out loud, is that I think private equity is distinctly different from nonprofit healthcare.
Great. I think that it's almost time to move on to the second topic, but I don't want to, if anyone's got burning things they want to say. One thing I will note is that I heard a sort of a thread in several of your comments. So I heard Amy talking about some of the perverse incentives created by 340B. I heard Lynn talking about sort of this licensing process with providers, and also like those things that have sprung up unintendedly because of No Surprises Act, and the ways that I heard Mallory talking about like the ways that price transparency information is being used in ways that weren't necessarily intended. So I just wanted to test out with you all. So, and in a way, all of those are unintended impacts of public policies that, so what is that? So I think a theme for all of us probably throughout all of it is how do we, and we couldn't have anticipated some of those things, right? That like the No Surprises Act intermediaries, for example, but and the Medicaid cost shift, which came up earlier, is another one of these. So how do we think about, well, first of all, there are distortions that exist today that are incentivizing some of this activity, but how do we think about also protecting against, fixing some of those and protecting against new ones? It might be more of a rhetorical question, but go ahead. Like, I don't know the answer to it, but I would love it if you do.
It's rhetorical. I have to answer. Lynn from Blue Cross. I think, looking at policies, it's really hard to put the genie back in the bottle for some of these things. And so how do we bring facts and data to the No Surprises Act to make some changes, not take it away? We don't want to eliminate the consumer protections that are in that, but how do we fix some of those things? And I'm not just saying to that one, but when we see unintended consequences happen in public policy, and there's data and information that we can go back and together say, hey, this really isn't working. How do we have to change this? But there's going to be groups that are going to come forward and say, absolutely no way, no how. This is what we wanted, and this is how we're going to go forward, regardless of those impacts. And so I think that's where the struggle is really coming forward with data-driven information to say, this is how it's impacting the consumer. And then understanding who is behind certain policies or advocacy coming forward. Because it may not be the entity that is the voice, but there's money behind it. And so following the money on who is driving that public policy will give us a good indication of what their motives are. And so I think that's really important as we move forward. I mean, we can't go back with all these things, but we can see the writing on the wall as we're piecing this together about how we move forward on, again, bringing data and information to the policy making. That's really hard because it's so political, right? By nature. But how do you get that policy driving it outside the perhaps legislative process? And I appreciate and I respect the legislative process more than anyone, maybe not more than anyone, but I do respect it. So I just want to be able to drive it in a way that matters.
Yeah, go ahead, Amy.
And I just want to be clear. It is the abuse of 340B by its intent. It is a great piece of legislation to protect the and underinsured, right? By its inception, it just has become something it shouldn't, right?
Yes.
But I do want to call out the state of Minnesota, the only state in the United States who has published their 340B data, period, this year, despite discussion that was something that was called upon by all states to have transparency. So I actually applaud the state of Minnesota for that. So to answer your question, I think awareness and being able, like private equity questions that are out, just getting the data and making the public and our consumers and providers aware of the system. And like I said, I have friends that went private equity because they wanted to stay private practice. This wasn't ill intent from physicians. This was just a desire to keep their independence, that they didn't realize the ramifications of the decisions, and that machine called the business side of medicine. Physicians don't get educated on the physician side of medicine, right? Until I was a shareholder in my own practice, I didn't understand the economics of the system I was working in. So education to providers, education to the public, data, transparency, all of this, I think will help.
Great, thank you. Alex, I wonder if you have anything to add as we wrap up this topic, or?
Oh,
Go
just
ahead,
one
Tyler.
final comment. Tyler Winkleman, Hennepin Healthcare. So I think you had asked about Minnesota specific context. I think three things that come to mind in Minnesota, at least in our current environment, that are challenges probably for this priority and for the others, is one, our lack of IT infrastructure that makes a lot of this challenging, both internally at the state and also through HIE and other tools to connect these players. Two, I do think it's important to acknowledge somehow in these priorities that the challenges at DHS, both from internal challenges and from challenges being put on them by the federal government, are a huge issue in trying to do any of this and sort of move policy forward that will require DHS's buy-in and input, are extremely challenging with the environment that's at DHS right now. And then three, MDH has severe financial challenges because of federal budget cuts and underfunding by the state legislature. And so I think those are three Minnesota core situational awareness pieces that do need to be part of the conversation as we think of creating the environment in which these recommendations can thrive.
Thank you. Sure, go ahead, Susan.
Can I ask kind of a process or follow-up next steps on this topic in specific and your thoughts on it? And that is, to Lynn's point that you can't put a genie back in the bottle, right? To the point that, well, we have not seen a lot of private equity in our medical space yet in Minnesota. There is a lot of national experience and a lot of information nationally about that. Our first next step would be, well, we don't know what we don't know. Let's gather more information so we know what is and isn't going on in the state, right? That's an obvious next step, but that can take years, right? And there is knowledge about what makes for good private equity investment and what doesn't. What would the comfort level be in this state for moving forward with policies to incent, and this obviously requires definition, but good private equity investment versus bad private equity investment? What would be the climate of trying to move forward on some policies without having gathered that information? That's my question. Do you spend the next 3 to 5 years gathering the information to make the policy, or do you start moving policy forward based on what you know nationally? You all probably know a lot more about this topic than I do, so I just thought it'd be interesting to hear your thoughts on it.
Lynn.
I appreciate you thinking about that. How do we discern what's good and what's not without having some of that information? I don't know. I've seen some of the motives behind be not good and really want to had their bottom line. And so some of those policies, like only getting commercial rates, that's strictly to pad a bottom line. That's not for access or for member services. So how do we quantify that before we regulate it? And how do we make sure that we're not stifling some sort of innovation that could occur because of private equity? Because there might be some benefits there.
I keep tag teaming you. Sorry, this is Amy. I hate to say that. My veterinary care is private equity pretty much nowadays, right? And so the first thing that came to mind when you asked is I don't know why every time my dogs go in now, they need 14 tests, right? Same thing is happening in private equity-based healthcare, right? I know because I go to a dermatologist. That is a private equity. But you just start to ask, when we think about what is that profit-driven behavior, right? Like we know as providers in private equity, because of my friends I talked to, their staffing is minimal. I mean, you have to run lean and that's bad for, so can we look at cost or frequency of use of, I mean, tests or things like that? Is it patient experience? Heaven forbid we ask the patients how they feel that they have to go in, 3 extra times, it just patient experience, value of the care, like what is the quality of the outcomes of the care they're receiving? And these, so these come to mind, but it was just ironic. The first thing I thought of was my vet experience. But I think those could be things that you would want to absolutely know to see, because of those kind of incentives, like I started with, what is driving them is making profit, and those things should be taken into account.
Great. Mallory, and then I'll give Alex a chance. And then I love that our problem is that we all want to say too much. That's a great problem to have. I think what we might do is take our break a little early because I don't want to chop up our next discussion. So Mallory, and then Alex, and then a break.
I appreciate the question. On our first meeting, we talked about this concept of analyzing the problem versus moving forward. So thank you for asking that. And I agree with what my colleagues here have said before. I think it is in this space challenging to make or recommend policy that could stifle or chill innovation that we might really need in healthcare spaces. I also think there's challenges in creating statewide policy where perhaps it could be different based on rural or urban healthcare or the specialty or service line, behavioral healthcare versus surgery centers, for example. And so I think in this space, and I think Sean said this too, there might be a little more segmentation of data that we need to do to really understand before we recommend policy. So that's my perspective.
This has been really helpful, and I just want to reiterate something I think someone said about just the interconnectedness of topic 1 and topic 3, right? And they are different, and I've heard that here, and the Healthcare Affordability Advisory Task Force has also highlighted that. But there's someone, I think it was Representative Ryer, actually participated in the May 20th public conversation about these many topics, and made the comment that really there's a broader trend that she sees, at least, that this is about corporatization of the healthcare system. And so just, I don't think we need to sort of, that doesn't need to change the conversation much, but just wanted to react to what I'm hearing a little bit. Thank you for the input. So should we pause now then?
Yes, let's take a 10-minute break, which I think would bring us back at about 10:32. All right, see you back then.
Yeah, so.
Just
Figured out how to do that. All right, so we should begin.
But yeah, so we just use, we can just hit neutral. We are, we don't use it all the time. Yeah, like last couple of years, we've been breaking. But it's so much, so worth it.
Haley's invitation.
That's.
And I think that's good. Yeah.
Wow.
Yeah. Trained.
Yeah.
And actually, I read that way because you're not driving the care decisions, you're having healthcare conversations. So I actually think it's gonna be really effective.
All right, we're going to get back together. Thank you for taking your seats.
At United and St. Paul. Yeah. I used to work there.
God forbid, nobody has healthcare problems on the weekends, by the way. Did you know that?
Yeah, no, never.
Nobody has a.
Are you have an office in Fort Road or where are you?
No, we're all off campus from there, so I actually see patients in Woodbury.
Oh, really?
I just operate at.
Richie Surgery Center or patients?
Yeah, because big ovarian cases across the street, about 80% of what I do is robotic, so same kind.
You using the DV5 or still the excise?
Whatever. We have one of the, I actually don't love the new one. It doesn't.
Do anything extra, right?
No, I think it's cool for the robot because it does, like, that's a change. I mean, and that can, this will collects data. Collects data, I don't know.
Yeah. For what purpose, right?
Right.
So the company gets it?
Yeah.
All right, everyone. Thanks for a great conversation on topic number 1. We're ready to move on. And just as kind of a little bit of a reminder and framing, the first 2 topics that we're talking about are come out of this sort of like broader interest in what we have been calling like non-value added spending. So ownership is one of the topics that was prioritized under that, but pharmacy benefit managers is the second of the 2 non-value added spending topics. And if any of you have like a better idea than calling this thing non-value added spending, we are all ears. But the idea is like there's just like a lot of money in the system that isn't necessarily creating value. So our second topic is the role of pharmacy benefit managers. And the way that we are currently describing it is talking about analyzing PBM financial practices in Minnesota, including rebates, spread pricing, administrative fees, vertical integration. All of those, I mean, this is the topic area that is, I would say, exceedingly complex. I think it takes a lot of study to really understand it. And myself, sometimes I feel like I've only scratched the surface, and it's one of those things that also changes pretty rapidly as well. But some of the policy options that are like part of, the landscape of what could be considered or, the idea is that to identify policy options that improve consumer affordability and transparency, along with fair pricing for pharmacies, because that's a topic that's come up in the affordability task force about like, what's the impact of that pharmacy benefit manager having like on the ability of independent pharmacies, particularly, and especially in rural areas to continue to exist. It's related to the point that Amy was making earlier about access, like physical access to services and some kinds of things that you can only do in person. So we have the same set of questions for you. So I warned you that we were going to ask you the same 5 questions each time. And I'll go to those, but also want to give the opportunity to Joel and Gita to kind of set the stage for this discussion.
I'm going to be really brief here. This is the topic I know the least about. PBMs to me are a cloudy black box. And I think transparency and finding the right amount of transparency. I will say that your comment is right on. In my community, this really became the death knell for any independent pharmacies, and we no longer have any. They're all system-based, Walmart and others.
Sitting in the broader task force, I think was clearly a lack of understanding about what PBMs do, but the topic to me was much broader than the pharmacy benefit manager, but I was thinking about when I started working at UCare, what the percent of all of our expenses were related to pharmacy, and then what it was when I left in 2023. And so I think they're interwoven in here. The pharmacy benefit manager is not the only part of this that's causing the drive and cost changes.
Thanks for that, Gita. So here are our questions. Let me know if you want me to just flip back to the other slide too, that just kind of like gives us the overview of the topic. Yeah, we're looking at, so like to your point, Gita, yes, like it's not surprising that a lot of people don't understand what PBMs do, but like, so one question, so thinking about like the role that you sit in as like is either payers or providers, what do you notice, or like what are some of the key insights related to this topic that you would like the Affordability Task Force either to know about? So like we can, like, you can impart this knowledge directly, or you could tell us, well, here's what you really need to go find out. So we're not looking at you to have all the answers, but to help us understand, like, what is the path that we need to follow to get the answers. Amy.
Yeah, so Amy, provider. So I would say from a patient-facing issues with PBMs, I have seen it where patients of mine or in the group can no longer get access to drugs at their local pharmacy. And so I think to your point earlier, it talks about it's an access question. I think that there's evidence of potential increased cost to patients once they are able to get the drug, maybe not at their local pharmacy, or maybe for those that it hasn't changed their local pharmacy, questions about increasing cost of the drug, which is an issue from the patient standpoint, clearly. And then we've seen delays. So in the oncology setting for patients whose medications have to go through a PBM, we see delays in getting prior authorization or access to medications, which in my setting in cancer is clearly a big issue or concern from an outcome standpoint. So I would say those are three things that need to be taken into consideration. From a practice standpoint, the PBM market has put additional pressure on private practice. We have our own pharmacies, and that is a revenue source. Just to be clear and open and honest, that is a revenue source that our practice uses for our ability to keep our doors open. And so when PBMs get into the market and we lose, those prescriptions get directed away from our own pharmacy. And so it's not that I'm expecting people to be like, oh, I'm so sorry about your practice revenue, but if we don't exist, there goes a consolidation issue. The more consolidation, the more you contribute to less competition and drive up cost.
Kevin, yeah, you looked like you were going to jump in.
Is this mic on? This is Kevin from Essentia Health. I think this is an exceedingly important topic. I'm really glad that we're exploring it. Pharmaceutical costs is the single highest inflation item for us as a health system. And it's also the largest driver of our increase in employee health plan costs. It's a massive issue around healthcare inflation. PBMs are very hard to understand, right? And even knowing what I do, and we run a lot of pharmacy operations, but the inherent conflicts of interest, owning all pieces of the supply chain, make it very difficult. I'll pick on CVS because they're not in the room today, but if you are insurance and you're a PBM and you provide the actual drugs, you can set prices, or in the retail pharmacy operation that are below cost and really drive competition, drive competitors out of the market. And I think that there is anti-competitive behavior. At least I've seen some evidence of that. So, networks being really open to other bidders. I think transparency, there's no transparency in this area. Like, what are the relationships? How do they work? Access and exclusivity around drugs. So like sometimes even when you're in a network, you can't get the actual drug to provide to a patient. And I think that there's potentially some anti-competitive elements of that. And then what's the value to the patient around PBMs? Are they really lowering drug costs? I don't see evidence of that. And are the incentives aligned to try to reduce drug costs with PBM operations? Those are all some key questions. Thanks.
Sean and then Lynn.
This one for me, Julie, starts first with a question that I think you asked earlier in regard to how does the task force prioritize among the 7 initiatives that they've narrowed it down to now? Starting first with that much larger list that you showed us. This is an exceptionally important topic, so I'm aligned with everything that's been said about it, and we need to figure out how to address this here. But given recent developments at the federal level, looking at important regulatory changes that will hopefully shape the market in a productive fashion for us to get a better handle on this, as well as recent things that have happened at the state level as well that have just recently been put on the road, don't actually know where they're going to go. I kind of think, given the complexity here, that this one would drop lower on the list for our task force to address. If that's not the right way to think about it, I think then that I go to the Minnesota specific context next. Like, what is unique about us here in Minnesota as far as this topic is concerned that would, perhaps make it easier for somebody who's viewing this like I am to understand, oh, okay, I get it. That's what we're going to do here in Minnesota on this topic. So hope that makes sense.
Lynn.
Yeah, Lynn from Blue Cross. And I think I agree with all the comments. I think we need like a baseline of understanding because Minnesota was really at the forefront of putting in some regulations for PBMs a few years back, and then recent changes at the federal level and reconciliation that changes regulatory requirements and transparency around PBMs and how it impacts consumers and affordability spending, whether it's in commercial market or in the Medicaid market. So I think some of those questions, or maybe more of a level setting on education, would be helpful before we prioritize this, because it has had a lot of focus from a policy perspective at the state and federal level. And then I just want to say part of the, middlemen or whatever, some of those words are coming from the pharmaceutical companies. We know that. And so if you think about that, they're trying to put them at the focus and not the prices of pharmaceuticals. And so that's just a really important context to understand as they protect their prices and increasing their prices whenever they can.
Kate.
I have a lot of thoughts and I was just trying to figure out how to consolidate them all down. I agree with a lot of what's been said about this. Seems it's a complex issue. I think it overlaps with consolidation and vertical integration. To Joel's point, I hear from my patients in the Twin Cities here that they have the best experiences at our independent pharmacies and the worst experiences at our large corporate pharmacies. And I think that is a huge disadvantage if they're going away as a result of PBMs or, pharmaceutical complexity. I think this is also the biggest question mark for physicians is I can't predict for a patient what their drug is going to cost. And they ask me that all the time. And I would love to be able to help them choose something that's going to feel more affordable, but I have no idea what that's going to be. Like I can make maybe a guess, but then 30% of the time I'm just wrong. So I just don't guess anymore. But it's led to a lot of us using discount pharmacies like Cost Plus, Smart Cuban, those sorts of places, just like getting out altogether because that's the only place that I know reliably what it's going to cost. And it's often cheaper than what it would have been, even if they have pretty good insurance. And my other question is like, to kind of Lynn and Amy's points about like, we have this prescription drug affordability board. My understanding is it has like pretty good power in Minnesota as compared to a lot of other states. And I don't think that a lot has been like, maybe we aren't leveraging that power as much as we could is my question. I don't know the answer to that, but it is on my mind.
Alex, were you going to jump in?
Quickly address the PDAB issue. And I also want to make sure to get to anyone online. I think Cassandra and Svetlana are online, but just wanted to invite them to chime in as well on the Prescription Drug Affordability Board. The PDAB, we do have a PDAB in place just over the last, I think it was passed in 23, and we are in close coordination with them. So I just want to make this group aware of that. And we are talking with the Healthcare Affordability Advisory Task Force as well about just coordination and ongoing, just making sure that we're tracking with them. There are other states that do have PDABs that have an upper payment limit ability, like a policy authority to set those payment limits. And Colorado, I think, has had that same authority maybe for like 4 to 5 years and have only now over just this year gotten to their second drug. So in other words, this work just takes a really long time. So just wanted to reiterate that like that is something we are watching too and wondering about what kind of partnership or role these two entities should be having, but appreciate the comment.
Cassandra or Svetlana, this would be a good time to jump in if you want to add. Not that you have to, but just want to make sure that we give you space for that.
I don't think I have anything to add that others haven't already said. Thank you.
Same with me.
Oh, go ahead. Thank you. Go ahead, Amy.
Can I just, because I am on the PDAC, but we're going away per legislation probably in August. So the PDAC will likely no longer exist. PDAB will move forward. It's interesting because as we were talking about Colorado, they just were setting those upper limits, but now have been sued by Pharma. So I just want to let the group know they are doing that, but how effective that work is going to be because now, not surprisingly, Pharma is not happy.
Can you give us a little more context about just for the folks in the room and online about what the PDAC is and how it relates to the PDAB?
So I would have, when we started this, would have assumed that the PDAC, my experience there would have been similar, but as I think I shared at the first meeting for this group, this is a much more organized, thoughtful start than we had on the PDAC, right? But the PDAC has similar stakeholders, not just physicians and payers, but multiple other descriptions of stakeholders that are there to advise the PDAB as they are making decisions about affordability of prescription drugs. So that was the plan. We had set all the stakeholders put together our definition of what we thought affordability meant, right? Because the question is what does that mean to each stakeholder individually? So we put that together waiting for the PDAB. We have a conflict of interest, that we put together because that's part of it, but now we're no longer, right? So moving forward, the PDAB is just starting their work to talk about which drugs they're going to be considering. And in this, I believe June and July are when those first discussions are moving forward. So the PDAC was quasi supposed to be informing and supporting the PDAB.
Okay, thanks.
PDAB, Affordability Board, and a DAC.
DAC is Affordability Council or Committee. Yeah,
thank you.
Yeah, which would then kind of like what this group does for the board.
Okay, and just for clarity, right? So that was the PDAB, Prescription Drug Affordability Board,
Yeah.
is intended to tackle some of this question that like is also coming up here about like, well, also the prices of the drugs themselves is really important.
Right, because we haven't
Yeah.
really talked about, I don't know if they're talking about like PBM, to me has not been a concept that's brought up. They're literally looking, at least directly of my awareness, they're looking at individual drugs to decide what to do about it, like these upper limits, et cetera. Maybe they're going to get into PBMs as well, but I just haven't heard that rumor.
Okay. Any other thoughts that you all want to add or perspectives you want us to make sure get shared with the Affordability Task Force? Thanks, Joel.
It's interesting to hear about this because I really didn't know anything about what those groups were doing. It strikes me that we do not have the depth of knowledge around this table as it relates to the PBM side. And if that group doesn't either, maybe there's a question of, do we need to add somebody to one group or the other who can bring that value and knowledge base?
Thanks. So it sounds like, I mean, I don't want to put words in your mouth, but heard a few comments about like there's other policy changes in flight. We don't have the technical knowledge to inform it. So this is probably not one that you guys would put at the top of your list to tackle first. Would that be a fair thing to say? Okay.
But I don't think we're saying it's not important.
Yes, correct. Thank you for that. Yeah.
Very important, actually.
Yeah.
All right. So let's talk about our topic 3, which we've already noted has some overlap with topic 1, but we've also noted that they are distinct in some important ways. So market consolidation, developing a deeper understanding of healthcare market consolidation, including mergers and acquisitions involving both Minnesota-based and out-of-state entities, how those affect healthcare prices and spending, and identifying policy options to reduce their impact, the impact that they may have on increasing prices and spending. Same set of questions. Who wants, let me offer the opportunity to Joel and Gita to kick us off.
I've already stated a couple of things here in earlier discussion. Obviously, there's a lot happening, has been historically, and there is contemporaneously, obviously going on, formal and informal. I'll remind groups like we have the Headwaters Network, of which my organization is part of, trying to achieve some of the same objectives in a virtual integration, for lack of a better term. For me, the thing here is mechanisms already exist to review these, either at federal and state antitrust or the Attorney General's office. So the question is, are there deficiencies within that we're concerned about? That maybe there become policy recommendations? Is there something missing out of those reviews that are not hitting the right mark as it relates to affordability? Or is that really even being strongly considered within their processes?
As we heard the task force talking about this, and then at our group meetings, the difference between nonprofit and for-profit entities coming in with this has been important in some of the limitations. But as we go back in time and think about the anxiety that occurred when Sanford and Fairview were going to merge, and they were being seen as an out of state, even though they did have some providers in Minnesota, versus Sutter and Alina coming together. It's real issues here. And I think part of the question is, we understand the cost impact side of it, but will the providers survive if these consolidations or mergers do not occur? And trying to unpack this so we're not losing access at the same time we say this is bad or it's going to cost more.
Mm-hmm. So I think to paraphrase what you said, Gita, it is, so you have to think about the circumstances in which the transaction or whatever is occurring, because you are right that sometimes the alternative is for the entity that's being acquired to go out of business, and would that be better or worse? What else? Mallory?
I think I'm gonna use this mic, even though I heard that one's working. I will start. I'm Mallory with Alina Health, and I want to disclose just right away that I do have, I think, a conflict of interest here as I work for one of the large health systems that's currently in partnership. And want to share my perspective here, and want to start with a story about our current state as a large health system in Minnesota. And this morning I was talking to one of our stroke neurologists. We've had some really incredible outcomes at our community hospitals around stroke care because of some new technology we were able to implement, where our stroke neurologists can actually read the images before the page happens, which we all know time is brain, and the outcomes are drastically different when you can respond quickly. And so I think about that story and the care that we're able to provide in rural communities and the trajectory that that changes for our patients. And without being a health system, that would look different for some of those communities. And so want to just provide that perspective based on our current state in my morning meeting with our neurology team. And I think to your point, Keita, there's lots of things to consider here. What's the alternative in our current state, and with what we all are expecting, the impact of HR1. This task force was established because our current state in Minnesota is unsustainable. And so I just offer that to the Healthcare Affordability Task Force as well. How do we think about that? And then similar to my comments earlier around ownership models, I think a one size all here is really difficult. Services, geography, we look at, Minnesota as a broad state. It's hard to think about policy that may, and the implications of statewide policy and the impact of those in some of our smaller and rural communities and reservations. And then maybe my last comment would be echoing Joel's first comment is, there are legal processes in place. And so I would ask, maybe the task force to better understand what about those isn't addressing some of the concerns and what we're seeing nationally, and how do we better understand that. So I think those would be my initial comments.
Thanks. Amy, go ahead. And then Kevin.
I think to add comments, I think, Geeta, your point of just what is at risk, right? When these scenarios come up, I think of the bigger question of when the point about the out of state coming into Minnesota. One